Practice-changing studies in treatment-naive chronic lymphocytic leukemia. Updates from ASH 2019. My name is Versha Banerji, and I'm a hematologist at Cancer Care Manitoba. Here are my disclosures. I have participated in advisory boards or received research funding from AstraZeneca, AbbVie, Janssen, Roche, Gilead, and Teva. I have received research funding from the Canadian Institutes of Health Research, Leukemia Lymphoma Society of Canada, Cancer Care Manitoba Foundation, Research Manitoba. Impact Medicom received funding from AstraZeneca for the development of this slide presentation. Frontline treatment recommendations for CLL in Canada. Current frontline treatment is stratified by risk. These include the 17p deletion or p53 mutation or other high-risk features, such as IGVH unmutated status or 11q. The definitions of high-risk features do vary province to province in Canada, but the presence of those high-risk features really do determine what type of treatment should be initiated. So if a high-risk feature is present, we ask the question, yes or no. If the answer is yes, the treatment is continuous ibrutinib monotherapy. If the answer is no, the next question we ask is the patient fit? If the answer to that question is no, the treatment choice is chemoimmunotherapy, specifically with chlorambucil or obinutuzumab, or if the patient is unfit for chemotherapy, they could also receive ibrutinib monotherapy continuously. If the patient is fit and the answer is yes, the next question we ask is the patient less than 65 years of age? If the answer to that question is no, standard treatment would be bendamustine plus rituximab as chemoimmunotherapy. If the patient is less than 65 years of age, standard treatment would be fludarabine, cyclophosphamide, and rituximab. Current clinical trials are trying to address the following questions in the frontline setting. Is there a subgroup of young or fit patients that would benefit from ibrutinib-based therapy over FCR? Are second-generation BTK inhibitors a viable option in treatment-naive CLL? Do they have an improved safety profile over ibrutinib? Is there a role for fixed-duration therapy with novel agents in the frontline setting? In this talk, I will summarize the clinical trials presented at ASH 2019 that have practice-changing potential in treatment-naive CLL. We selected oral presentations from ASH 2019 that reported on phase 3 trials for frontline CLL therapies. These include ibrutinib and rituximab provide superior clinical outcome compared to FCR in younger patients with CLL, extended follow-up from the E1912 trial, abstract 33, phase 3 study of acalabrutinib combined with obinutuzumab or alone versus obinutuzumab plus chlorambucil in patients with treatment-naive CLL, results from the ELEVATE-TN study, abstract 31, efficacy and safety of zanubrutinib in patients with treatment-naive CLL or SLL with deletion 17p, initial results from the Arm C of the SEQUOIA study, abstract 499, and quantitative analysis of MRD shows high rates of undetectable MRD after fixed-duration chemotherapy-free treatment and serves as a surrogate marker for progression-free survival, a prospective analysis of the randomized CLL-14 trial, abstract 36. Currently, Health Canada has approved the following agents that have been studied: ibrutinib and acalabrutinib. Ibrutinib is approved for previously untreated CLL as monotherapy or in combination with obinutuzumab, relapsed CLL as monotherapy or in combination with BR. Other indications also include mantle cell lymphoma, marginal zone lymphoma, Waldenstrom's macroglobulinemia, and graft versus host disease. Acalabrutinib has Health Canada approval for previously untreated CLL as monotherapy or in combination with obinutuzumab, relapsed CLL as monotherapy, and other indications include mantle cell lymphoma. Currently in Canada, zanubrutinib does not have Health Canada approval, but has FDA approval for mantle cell lymphoma. Other novel agents include BCL2 inhibitors. Venetoclax does not have Health Canada approval in the frontline setting. In the relapse setting, it is approved in combination with rituximab in a time-limited duration or as monotherapy continuously. Our first abstract, abstract 33, is Ibrutinib and rituximab provide superior clinical outcome compared to FCR in younger patients with CLL, extended follow-up from the E1912 trial. The study design, key eligibility factors include previously untreated CLL, requiring treatment by IWCLL 2008 criteria, age less than 70, ECOG performance status between 0 and 2, creatinine clearance greater than 40, able to tolerate FCR, and no deletion 17p by FISH. Patients were randomized in a 2-to-1 manner to ibrutinib and rituximab, or standard of care fludarabine, cyclophosphamide, and rituximab, or FCR. After completion of the chemotherapy or combination treatment with ibrutinib, patients in the ibrutinib arm went on to receive ibrutinib daily continuously until progression. In this study, there was an evidence for the first time of a novel agent having an overall survival advantage compared to standard chemotherapy. In this study, the overall survival advantage was 99% in the ibrutinib-treated arm, opposed to 93% in the FCR-treated patients, with a median follow-up of 48 months. The progression-free survival was 89% for ibrutinib-treated patients and 71% for fludarabine-treated patients. One of the key findings presented at the 29 update was a progression-free survival by IGVH mutational status. For IGVH mutated patients, there did not seem to be any benefit of a novel agent, with progression-free survival at 3 years of 88% in the ibrutinib-treated arm and 82% in the FCR-treated arm. However, for the unmutated patients, ibrutinib did have a significant progression-free survival advantage at 89% at 3 years, opposed to 65% at 3 years with fludarabine. Another key point that came of this study was what happened to patients after ibrutinib discontinuation. In the study, there were 352 patients who started on the ibrutinib arm. There were 95 patients who discontinued treatment. 7% of the total population discontinued because of progression or death. In the patients who discontinued, 24% discontinued because of progression or death. Of the 72 patients who stopped ibrutinib for reasons other than progression or death, the median progression-free survival post-discontinuation was 22.5 months. This is a very important point for a treatment that's given continuously, as patients can do really well if they discontinue therapy. In a multivariable analysis, only SIRS score predicted ibrutinib discontinuation. Here were the grade 3 to 5 treatment-related AEs throughout observation. The key factor here is when you look at the two columns, the adverse events do not overlap. For chemotherapy or FCR treatment, the majority of the AEs are related to cytopenias, such as anemia, low neutrophil count, or febrile neutropenic episodes. The AEs related to ibrutinib-related treatments are similar to those that we see with monotherapy for ibrutinib: arthralgias, diarrhea, hypertension, atrial fibrillation, and other cardiac events. In conclusion, ibrutinib plus rituximab continues to provide superior PFS and OS compared to FCR in younger patients with previously untreated CLL. There was no increase in PFS benefit seen in IGVH mutated patients. Longer follow-up is needed to confirm an OS advantage for the ibrutinib treated patients. many patients who discontinue ibrutinib for reasons other than progression or death could still achieve a durable remission post-discontinuation. The next abstract, Abstract 31, is a phase 3 study of acalabrutinib combined with obinutuzumab or alone versus obinutuzumab plus chlorambucil in patients with treatment-naive CLL, results from the Elevate-TN study. The study design: treatment-naive CLL patients aged greater than 65 or less than 65 with coexisting conditions, a SIRS score of greater than 6, or creatinine clearance less than 70. Patients were stratified based on their risk, their functional status, and geographic region. Patients were randomized in a 1-to-1-to-1 manner to acalabrutinib plus obinutuzumab, acalabrutinib alone, or chlorambucil plus obinutuzumab, the standard arm. Patients who progressed in the standard arm were able to cross over to the acalabrutinib monotherapy arm. The primary endpoint of this study was progression-free survival of acalabrutinib plus obinutuzumab versus obinutuzumab plus chlorambucil. The key secondary endpoints were progression-free survival of acalabrutinib monotherapy versus obinutuzumab and chlorambucil, the overall response rates, times to next treatment, overall survival, and safety. It is important to note that this study was not powered to find a difference between acalabrutinib monotherapy compared to acalabrutinib plus obinutuzumab. The IRC-assessed progression-free survival with a median follow-up of 28 months was not achieved in any of the acala-containing arms, and it was significantly greater to the standard arm, where PFS was 22.6 months. When looking at subgroups, such as bulky disease, presence of 17p or p53 mutation, deletion 11q, IGVH mutated status, or complex karyotypes, all subgroup analyses favored acala plus obinutuzumab or acala alone. The only subgroup that crossed over one was mutated patients receiving acala monotherapy. The overall response rates for the acalabrutinib arm was 93.9%, 85% in the monotherapy arm, and 78.5% in the standard arm. Overall survival rates at 30 months were 95% for the acalabrutinib arm, 94% for the acalabrutinib arm, and 90% for the obinutuzumab chlorambucil arm. Of the 82 patients who progressed on the chlorambucil plus obinutuzumab arm, 45 patients crossed over to the acalabrutinib monotherapy arm. Overall survival was not reached in any group. The most common adverse events present in greater than 15% of patients in any arm are listed here. The ones that I'd like to draw your attention to are those that are either associated with antibody administration or acalabrutinib therapy. The infusion-related reactions were present in patients who received obinutuzumab, and these were not significantly different amongst what we expect in patients who receive obinutuzumab. I think what is important to note is that there was a reduction in the degree and the grade, as well as the number of patients who had infusion-related reactions. One of the side effects that is present with acalabrutinib is headaches. It is something that is easily treated with Tylenol-based therapy, but is something that is different from other BTK inhibitors or novel agents that we use for the treatment of CLL. When we look at the serious adverse events, these were more frequent in acalabrutinib plus obinutuzumab compared to chlorambucil and obinutuzumab, but not very different when we look at the acalabrutinib containing arms. When we look at the cardiac toxicities or risks of bleeding, which are those associated with BTK inhibitor-based therapies, these are very similar to the rates that we see amongst other BTK inhibitors. atrial fibrillation, hypertension, bleeding, major bleeding, and infections. In conclusion, acalabrutinib as monotherapy or combined with obinutuzumab significantly improved PFS compared to the standard arm of chlorambucil and obinutuzumab. The study was not powered to evaluate a progression-free survival difference between acala monotherapy and acala with obinutuzumab. Despite crossover of patients in the chlorambucil obinutuzumab arm to the acalabrutinib arm, a trend towards improved OS was seen in both acalabrutinib-containing arms. Longer follow-up is likely needed to detect this difference. Acalabrutinib had a tolerable safety profile, not uncommon to what we are used to with other BTK inhibitors. The rates of atrial fibrillation, hypertension, and bleeding reported were similar or lower to those from other studies with BTK inhibitors such as ibrutinib. Efficacy and safety of zanubrutinib in patients with treatment-naive CLL or SLL with deletion 17p. Initial results from the Arm C of the SEQUOIA study. Abstract 499. Study design. The key eligibility criteria are treatment-naive CLL and SLL, meeting criteria for treatment by IWCLL criteria, age greater than 65 years of age or unsuitable for treatment with FCR, and in this study, anticoagulation and CYP3A inhibitors were allowed. Patients were randomized to cohort 1 or cohort 2, those with a 17p deletion or those without a 17b deletion. For the purposes of this presentation, we will focus on cohort 2, Arm C, where patients received zanubrutinib 160 milligrams BID until progressive disease, intolerable toxicity, or end of study. Here we see the investigator-assessed progression-free survival curve and response rates. The overall response rate was 92%. CRs were achieved in 1.9%, PRs in 78%, PR with lymphocytosis in 11.9%, stable disease in 5.6%, progressive disease in 1 patient. 4 patients progressed on this study. 1 confirmed a Richter's transformation. 1 patient died to grade 5 pneumonia. Safety results. The most frequent adverse events of any grade occurring in 10 to 20% of patients were bruising, upper respiratory tract infection, rash, diarrhea, nausea, constipation, back pain. Grade 3 or greater AEs were reported in 40 patients, and those that occurred in greater than 2 patients included neutropenia, pneumonia, and hypertension. Here is a bar graph demonstrating adverse events of interest by grade. We can see that infections were the most frequent, followed by bruising and minor bleeding. Neutropenia and infections had grade 3 or greater toxicities to a larger extent. In conclusion, preliminary results suggest that zanubrutinib is active and generally well tolerated in this high-risk population of CLL patients with 17p deletions. Rates of atrial fibrillation and major bleeding appeared lower than what had been reported for ibrutinib. However, longer follow-up and head-to-head trials are needed to confirm whether zanubrutinib has improved safety or over ibrutinib or other BTK inhibitors. Quantitative analysis of MRD shows high rates of undetectable MRD after fixed duration chemotherapy-free treatment and serves as surrogate marker for progression-free survival, a prospective analysis of the randomized CLL14 trial, Abstract 36. Study design, safety run-in phase with venetoclax and obinutuzumab, previously untreated patients with CLL and coexisting medical conditions, SIRS greater than 6 or creatinine clearance less than 70 mL per min. Patients were randomized to receive 6 cycles of venetoclax and obinutuzumab, followed by 6 cycles of venetoclax, or chlorambucil and obinutuzumab for 6 cycles, followed by another 6 cycles of chlorambucil. The primary endpoint was progression-free survival. Key secondary endpoints were response, minimal residual disease, and overall survival. Important to note in this study that treatment was discontinued after 12 months duration. Here we see the progression-free survival by IGVH mutational status. For the venetoclax obinutuzumab IGVH mutated patients, not reached. For the unmutated patients, also not reached. For chlorambucil and obinutuzumab, IGVH mutated patients had a better progression-free survival at 43 months. Those with chlorambucil and obinutuzumab, however, those with chlorambucil and obinutuzumab and who were IGVH unmutated had the worst progression-free survival at 26 months, with a median follow-up of 39.6 months. Here we see undetectable MRD rates at 3 months post-treatment completion. So after 12 months of therapy and 3 months of follow-up, MRD assessment was done. MRD can be detected by PCR or by NGS. The bottom line is rates of MRD undetectable status were higher in patients who received venetoclax and obinutuzumab opposed to chlorambucil and obinutuzumab, regardless of which mechanism was used to detect MRD. Minimal residual disease rates over time by PCR. What we can see here is venetoclax plus obinutuzumab had higher rates of MRD as visualized by these white portions of the bar graph. In addition, these rates were as high as 75%, but gradually over time and off treatment dropped to about 35%. Similarly, for chlorambucil and obinutuzumab, while patients were on therapy, there was MRD undetectability that was seen, but these rates were closer to 30%, but dropped off as patients discontinued therapy. Conclusions: time-limited therapy with venetoclax plus obinutuzumab demonstrated prolonged PFS compared with chlorambucil plus obinutuzumab in patients with treatment-naive CLL and coexisting conditions. However, an OS advantage for this novel combination was not seen. The comparator arm of 12 cycles of chlorambucil plus obinutuzumab differs from the Canadian standard of 6 cycles. Venetoclax plus obinutuzumab achieves high and sustainable rates of undetectable MRD. In summary, these results presented at ASH 2019 support the use of novel agents as the treatment of choice over chemoimmunotherapy in treatment-naive patients with high-risk CLL. Questions that remain: what is the preferential sequencing of BCL2 and BTK-based therapies? Which BTK inhibitor will offer the best benefit to risk profile for patients? Will long-term data show a benefit for novel agents over chemoimmunotherapy in low-risk patients, such as IGVH mutated patients? Will there be a role for MRD-based decision-making for drug discontinuation possibly in the future?